Hi children, today we are going to learn about disorders of skeletal muscles. It includes malignant hyperthermia and myasthenia gravis. We have already studied about muscular dystrophy in the previous video. In this video, we will learn about the malignant hyperthermia and myasthenia gravis. These are also comes under disorders of skeletal muscles. We will first discuss about malignant hyperthermia. Okay. So, malignant hyperthermia is a hereditary disorder of a skeletal muscle that classically presents as a hypermetabolic response to halogenated anesthetic gases or to the depolarizing muscle relaxant such as succinylcholine. Okay. So, this is a hereditary disorder of skeletal muscle and classically presents as a hypermetabolic response for the halogenated anesthetic gases or for the depolarizing type of muscle relaxant such as succinylcholine. Genetically susceptible patients can have a malignant hyperthermia reaction in response to triggering agents such as halogenated anesthetic gases and or succinylcholine, and more rarely to the stresses such as vigorous exercise and heat exposure. So all these four things can lead to malignant hyperthermia in susceptible individuals. Here what is happening? Due to this mutation, the RYR receptor is not well formed. So this causes uncontrolled release of calcium from the skeletal muscle sarcoplasmic reticulum, which leads to sustained muscle contraction. The sustained muscle contraction produces depletion in the ATP and dramatically it increases the oxygen consumption, carbon dioxide production, and it produces heat. The depletion of ATP stores leads to membrane integrity failure and cell content will leakage out, okay, such as potassium, okay, creatinine kinase and myoglobin. They will enter into the circulation. So what is happening here? Due to defective RYR1 receptor, which is present on the sarcoplasmic reticulum in the skeletal muscle, the calcium will be released uncontrollably and it leads to sustained muscle contraction. This leads to utilization of ATP and utilization of oxygen and production of heat and carbon dioxide. And this depletion of ATP will cause failure of the membrane integrity and leakage of the cell content, that is leakage of the potassium, creatinine kinase and myoglobin into the circulation. Next, coming to the actual RYR receptor. These ryanodine receptors, these are the ryanodine receptors. This is the skeletal muscle, this is the cardiac muscle. In both we have ryanodine receptor, but RYR1 is present in the skeletal muscle and RYR2 present in the cardiac muscle. RYR1 is present in the sarcoplasmic or endoplasmic reticulum membrane and it is responsible for the release of calcium from the intracellular stores during excitation contraction coupling in both cardiac muscle and the skeletal muscle. These RYRs exist in three isoforms in mammals. Those are RYR1, RYR2 and RYR3. All of these are having homotetrameric proteins. So they are made up of homotetramers. So learn about 1 and 2. Here we are exclusively talking about RYR1 receptor. See here, this receptor is coupled to voltage gated calcium channel, that is 1.1 in skeletal muscle and voltage gated calcium channel 1.2 in the cardiac muscle. The ryanodine receptor genes in humans, RYR1, the gene which is responsible for producing RYR1 protein is present on the 19th chromosome. Q means long arm, long arm of the 19th chromosome, and it spans 104 exons. And RYR2, the gene located is on 1q and spans for 102 exons. Whereas RYR3 gene is located on 15th chromosome long arm and it spans 103 exons. So this is the uh, genes. These are the genes for a ryanodine receptor. So this is the protein of the ryanodine receptor. See where the RYR1 is present. RYR1 is present in the skeletal muscles. Mostly the skeletal muscles are expressing RYR1 protein. And it is also present at low levels in cardiac muscle, smooth muscle, stomach, kidney, thymus, cerebellum, Purkinje cells, adrenal glands, ovaries and testes. And recently it has noticed that B lymphocytes are also having RYR1 protein. RYR2 is present in cardiac muscle and also present in high levels in the Purkinje cells of the cerebellum and cerebral cortex, and low levels present in the stomach, kidney, adrenals, ovaries, thymus and lungs. Whereas RYR3 present in hippocampal neurons, thalamus, Purkinje cells, corpus striatum, skeletal muscles, the smooth muscles of the smooth muscle cells of the coronary vasculature, lung, kidney, ileum, jejunum, spleen, stomach, uterus, ureter, urinary bladder and esophagus. So it is mostly present in the animals. So RYR1, RYR2 are very much important. What are the signs and symptoms of malignant hyperthermia? It includes tachycardia, tachypnea, okay. So increased pulse rate and increased respiratory rate, and hypoxemia, that is oxygen content decreased in the blood, and hypercarbia, carbon dioxide content increase in the blood, and metabolic and respiratory acidosis, hyperkalemia, that is increase in the potassium levels in the blood leading to cardiac dysrhythmias, and hypotension, decrease in the blood pressure, and skeletal muscle rigidity because of continuous muscle contraction, and hyperthermia, increased heat production. All these are the signs and symptoms of malignant hyperthermia. The earliest signs of malignant hyperthermia are usually hypercarbia and tachycardia due to increased carbon dioxide production. So how to evaluate the patient? The gold standard in the lab diagnosis of malignant hyperthermia is CHCT test. That is caffeine halothane contracture test. What is that? Caffeine halothane contracture test. Although genetic test can also be done, okay, but it is under study. The CHCT involves exposing a sample of live muscle fibers to halothane and caffeine to determine the muscle response to halogenated anesthetics. So we have to take the live muscle fiber from the patient and expose it to halothane and caffeine and see the response. Okay. And second test is genetic testing. So genetic testing we will see for the mutations of RYR1 receptor or any other associated genetic variants associated with malignant hyperthermia. Okay. These tests are expensive and they can only be available in certain centers only. Okay. Therefore, when presented with the patient for urgent and emergent surgery who has a history suggestive of a close relative who has had a malignant hyperthermia episode. So what anesthetist will do? They will usually provide a non-triggering anesthetic, which is typically a variety of combinations of IV anesthetic agents. So if a patient comes, but we don't know about his condition, whether he is having malignant hyperthermia or not, but his close relative had this complaint. So anesthesia should not give succinylcholine or inhaled anesthetic. So they will give IV anesthetic, which is non-triggering agent. Coming to the treatment or management. So the critical element in the treatment of this malignant hyperthermia is immediate administration of dantrolene. Okay. Once a malignant hyperthermia episode is suspected, all triggering agents must be stopped immediately, and the patient should be hyperventilated with 100% oxygen with a non-triggering anesthetic agent, and surgery should be ended as soon as possible. So, how dantrolene should be given? Dantrolene in a dose of 2.5 mg per kg must be administered IV as soon as possible. And we can increase the dose up to maximum dose of 10 mg per kg until the reaction subsides. In addition to administering dantrolene, attention should be paid to correct the hyperthermia, acidosis, hypoxemia, arrhythmias, and we should preserve the renal function also. Arrhythmias can be treated with antiarrhythmic, and renal function can be protected from ATN, that is acute tubular necrosis, by maintaining the urine flow of at least 2 ml per kg per hour with the furosemide. So we have to give furosemide also. So we have to give dantrolene IV, and we have to give antiarrhythmic, and we have to give furosemide. You see the management algorithm. First, you should stop the triggering agent. Then call for the help. Then administer the dantrolene at the rate of 2.5 mg per kg until the reaction subsides up to a maximum dose of 10 mg per kg. And increase the ventilation to lower the end-tidal carbon dioxide. Then cooling measures like cold IV fluids and ice packs are kept to the exposed surfaces. Treat the arrhythmias, okay, with the antiarrhythmics like amiodarone. Avoid the calcium channel blockers. Lab studies should include ABG, that is arterial blood gas analysis, and electrolytes. Especially we have to see potassium levels, and serum and urine myoglobin levels we have to see, and we have to observe the coagulation profile. Continue the dantrolene at 1 mg per kg every 4 hours for 24 to 48 hours. And we should ensure the urine output of 2 ml per kg per hour. Okay. And mannitol 3 grams should be added in each vial of dantrolene. So these are the management algorithm for malignant hyperthermia. So up to now we have discussed about malignant hyperthermia. So why it is coming? Because of the genetic mutations occurring in the RYR1 receptors, which is present in the membrane of the sarcoplasmic reticulum of the skeletal muscles. So when you give inhaled anesthetic, halogenated anesthetic gases or succinylcholine, they will cause uncontrolled release of calcium from the sarcoplasmic reticulum of the skeletal muscle and leads to sustained contraction of the skeletal muscle and leads to increase in the oxygen consumption and increase in the ATP consumption and increase in the heat release and increase in the carbon dioxide levels. So the decrease in the ATP levels in the cell leads to disruption of the myofibril membrane, that is sarcolemma is disrupted. Then the creatinine kinase, myoglobin and potassium will leave out of the cell and they will enter into the blood. And all this can cause to increased heat production, that is malignant hyperthermia. So we have to take care when the when such a patient comes, when that is he had a relative who is experienced malignant hyperthermia. So anesthetic should not give halogenated anesthetic, and succinylcholine is also should not be given. So the care should be taken while surgery. And in some patients, it can be triggered by heat exposure and vigorous exercise also. Then we have seen the receptors, RYR1 receptors especially. Okay, it is attached to voltage gated calcium channel 1.1 in the skeletal muscle. And the genes which are involved in RYR1, 2, 3 receptors we have seen. Then we have seen the diagnostic criteria, that is genetic testing and CHCT test. Then we have seen the management algorithm. What are the drugs to be given and how to handle the other problems. Next, we will learn about the myasthenia gravis. What is this myasthenia gravis? Grave weakness of the muscles. This myasthenia gravis is an autoimmune disorder affecting the NMJ, that is neuromuscular junction. It manifests as a generalized muscle weakness, which can involve the respiratory muscles also and can lead to myasthenic crisis. This myasthenic crisis is a medical emergency. Myasthenia gravis is the most common disorder affecting the neuromuscular junction of the skeletal muscles. Okay, so this myasthenia gravis can come as a question. The classic presentation is a fluctuating weakness. So the weakness is not constant. It is fluctuating, and it is more prominent in the afternoon. It usually involves the muscles of the eyes, throat, and extremities. The reduced transmission of the electrical impulses across the NMJ due to formation of the autoantibodies against the specific postsynaptic membrane proteins consequently causes muscle weakness. So what is happening here? Autoantibodies are formed against the receptors, that is proteins present on the postsynaptic membrane at the NMJ. So what are they? Acetylcholine receptors. So acetylcholine receptors will be present on the postsynaptic membrane. Autoantibodies are formed in this myasthenia gravis disease. A wide variety of conditions can precipitate this condition, such as infections, immunization, surgeries, and drugs. Myasthenia gravis causes a significant number of complications. So, how this is important? It may lead to myasthenic crisis. That is an acute respiratory paralysis that requires intensive care, as well as adverse events due to long-term medication treatment. So long-term they should use steroids. So this leads to opportunistic infections and lymphoproliferative malignancies. So we have to understand the pathophysiologic mechanisms, clinical manifestations and treatment strategies for the myasthenia gravis for the better patient care and better outcome. See the etiology. Myasthenia gravis, similar to other autoimmune disorders, occurs in genetically susceptible individuals. The precipitating factors are infections, immunization, surgeries, and drugs. The commonly implicated proteins in the NMJ against which the autoantibodies are produced are, so these three are the targeted proteins against which autoantibodies are produced in myasthenia gravis. What are they? First one is the nicotinic acetylcholine receptors, which are present on the postsynaptic membrane, and musk protein, that is muscle specific kinase protein, and LPR4, that is lipoprotein related protein 4. So against these three, autoantibodies can be formed in the myasthenia gravis. See this agrin, LPR4 and musk protein, they will form a complex which is essential for the formation and maintenance of NMJ, including the distribution and clustering of the acetylcholine receptors. So this complex is important for a distribution of the acetylcholine receptors on the postsynaptic membrane. And approximately 10% of the patient with the myasthenia gravis will have a thymoma, and it is implicated in the production of autoantibodies. So in 10% of patients, thymus gland is producing autoantibodies. See this? This is LPR4, this is musk protein, this is agrin protein. So all these three. So this is agrin, okay, a musk and LPR4 protein. So these are important for a localization of the acetylcholine receptors. So this will induce acetylcholine receptor clustering. So this is called agrin induced acetylcholine receptor clustering. So if antibodies are present against musk or against LPR4, what happens? The acetylcholine receptors won't be clustering at the postsynaptic membrane. So it can also leads to grave weakness, that is myasthenia gravis. So the signal from presynaptic nerve terminal to postsynaptic muscle fiber membrane, the signal won't be passed and the muscle cannot be contracted, leads to grave weakness of the muscles. Next, coming to classification of the myasthenia gravis. So depending upon the type of clinical features and the type of antibodies present, the myasthenia gravis can be classified into various subgroups. So each group responds differently to treatment and hence carries a different prognostic value. So why we are classifying? Because each one has a different treatment and different prognostic value. First one is early onset myasthenia gravis. That is, the age of onset is less than 50 years. It is associated with thymic hyperplasia. So thymus is producing autoantibodies. Late onset myasthenia gravis. That is, age of onset is more than 50 years of age with a thymic atrophy. Next, thymoma associated myasthenia gravis. Myasthenia gravis with anti-musk antibodies and ocular myasthenia gravis. So, in ocular myasthenia gravis, symptoms will only present from the periocular muscles. And myasthenia gravis with no detectable acetylcholine receptor and musk antibodies. So, we cannot detect the antibodies against these two things. Coming to the pathophysiology. The pathophysiologic mechanisms in myasthenia gravis are dependent on the type of antibodies present. So the type of antibodies are also different in different types of myasthenia gravis. That is, in nicotinic acetylcholine receptor myasthenia gravis, what are the antibodies? They are of IgG1 and IgG3 subtype. They bind to the nicotinic acetylcholine receptor, which is present on the postsynaptic membrane of the skeletal muscle and activates the complement system. So, this activation of the complement system leads to the formation of MAC complex, that is membrane attack complex. So, this MAC complex brings about the degradation of the receptors. Okay. So, they may also act by functionally blocking the binding of the acetylcholine to its receptor or by enhancing the endocytosis of the antibody bound NCH receptor. So they will act in three ways. This membrane attack complex will be formed. Then this will degrade the receptors, okay, or it may block the receptor so that acetylcholine cannot bind the receptor, or the antibody which is present. This is binding. This is antibodies binding the receptor. So this whole thing will be endocytosed into the cell. So all these three are the ways by which MAC complex will be acting. In musk and LPR4 myasthenia gravis, the antibodies are of IgG4 subtype and do not have complement activating property. Then what they will do? They bind the agrin LPR4 and musk protein complex which is present in the NMJ. Okay. So what is the importance of this complex? It is for the primary function. What is the primary function of this complex? It is for the maintenance of the NMJ and distribution and clustering of the nicotine type of acetylcholine receptor. So when these antibodies are bound to this complex, what is happening? The complex is inhibited. So the inhibition of the complex leads to reduced number of nicotinic acetylcholine receptors. The acetylcholine which is released at the nerve terminal in turn is unable to generate the postsynaptic potential required to generate an action potential in muscle. Why? Because of the reduced number of nicotinic acetylcholine receptors. So this leads to muscle weakness. The weakness is more pronounced with the repeated use of a muscle group. Why? Because it causes depletion of acetylcholine also in the NMJ. So with repeated stimulation of the muscle, the weakness is increasing in the myasthenia gravis. Histopathology. So what are the histopathological conditions? The histopathological findings in myasthenia gravis differ by the type of antibodies present. So in the muscle, what are the histopathological features? In nicotinic acetylcholine receptors of a myasthenia gravis type, the muscles show significant atrophic changes, whereas in other forms there are minimal muscle atrophic changes. But there are significant mitochondrial abnormalities. That is, mitochondria will become giant, swollen, and it may show some degenerative features. So in acetylcholine receptor type of antibodies, the muscle will be atrophic. In myasthenia gravis, the mitochondria will be abnormal. The differences suggest different pathophysiologic mechanisms of the two subtypes of myasthenia gravis. And neurogenic atrophy seems to be prominent in the nicotinic type, whereas mitochondrial abnormalities are more prominent in the MuSK type. So what are these bulbar muscles means? The term bulbar muscles refers to a group of muscles present in the head and neck. So these muscles are involved in the speaking, swallowing, chewing, and holding the jaw in its place. Okay. Next, coming to the limb weakness. This usually involves the proximal muscles more than the distal muscles, with the upper limbs more affected than the lower limbs. So how the limb weakness will be? It is affecting the upper limbs, that two proximal muscles are affected. Then coming to the myasthenic crisis. It is due to involvement of the intercostal muscles and diaphragm muscles. And it is a medical emergency because the patient cannot take a breath. There are no autonomic symptoms like palpitations, bowel or bladder disturbances in a myasthenia gravis. Okay, as it is only involving the nicotinic acetylcholine receptors. The physical examination may reveal a normal muscle power because of the fluctuating disease pattern. So in such cases, what we should do? In such cases, repeated or sustained muscle contractions can demonstrate the weakness. Improvement is seen after a period of rest or application of ice, that is ice pack test. So we have to give rest and we have to apply ice. After that, what happens? The patient will show decrease in the weakness. The pupils, deep tendon reflexes, and sensory examinations, all these are normal. MuSK myasthenia gravis has clinical features that are quite different from nicotinic acetylcholine receptor myasthenia gravis. This MuSK1 is more common in females and relatively it spares the extraocular muscles. Okay, so it spares the extraocular muscles and it commonly involves bulbar muscles, facial muscles and neck muscles. And it is also a frequent cause of myasthenic crisis. Okay, so those persons who are coming with extraocular muscle weakness, they are mostly having antibodies against nicotinic acetylcholine receptors. And those coming with the bulbar muscle paralysis, they are showing anti-MuSK antibodies. Coming to the evaluation. How to evaluate a patient with myasthenia gravis? We can do many tests. So first one is the serologic test. So serology. We can demonstrate the anti-acetylcholine receptor antibody. This test is very specific and it confirms the diagnosis in the patients with the classical clinical findings. It is present in 4/5 of the patient with the myasthenia gravis. Okay. So generalized myasthenia gravis, this test is positive for 4/5 of the patients. But if only pure ocular type of present, it is positive only half of the patients. The rest of the patients, okay, about 5 to 10%, they will demonstrate anti-musk antibodies. And only in a few sporadic cases, both are present. Both antibodies are present in the same patients. In 3 to 50% of the patients, you can see seronegative to anti-AChR receptor antibody and anti-musk antibody. But you can demonstrate anti-LPR4 antibodies. Okay. So, anti-AChR antibody, they are present most commonly. After that, in 10% of the patients, you can see anti-musk antibody. 3% of the patients, you can see anti-LPR4 antibodies. And in 30% of the patients, you can also demonstrate anti-striated muscle antibodies. So if they are present, what is the implying factor? They are more useful as serological marker for thymoma. Especially these are present in the younger individuals. So if these antibodies are present, the thymus gland is releasing antibodies. So it will confirm this. So it is especially seen in the younger patients. Next, coming to the electrophysiological tests. So what are these two tests? First test is the repetitive nerve stimulation test. And second test is the single fiber EMG test. So these are relevant in patients who are seronegative for antibody testing. So you have done the serology testing and you have not seen any antibodies. Then we will go for electrophysiological testing. So both the tests will assess the conduction delays in the NMJ. Routine nerve conduction studies are usually performed to determine the functioning of the nerves and muscles before undertaking these tests. So routine in NCV should be performed before this test. After that, we will perform these two tests. So what is the first test? A repetitive nerve stimulation test, RNS test. How to do this? This is done by stimulating the nerve at 2 to 3 Hz. So this repeated nerve stimulation, what it causes? It depletes the acetylcholine in the NMJ and produces low EPSP, that is low excitatory postsynaptic potential. A 10% or more than 10% decrease in EPSP between the first and fifth stimulus is the diagnostic for myasthenia gravis. So this is one test. Then coming to the SFEMG, that is single fiber electromyography. So this records action potential from individual muscle fibers. So individual muscle fiber will be tested. And this allows the recording of the action potential simultaneously from two muscle fibers innervated by single motor neuron. So in single motor unit only you have to select two muscle fibers. So single alpha motor neuron is coming and it is dividing into many branches to supply many muscle fibers. So you have to select two muscle fibers which are innervated by single motor neuron. Now what you should do? You have to stimulate the nerve. Then you should see the difference between the time of onset of these two action potentials. This difference in time is called jitter. Okay. So in one muscle fiber, what is the time of onset of action potential? And in another muscle fiber, skeletal muscle fiber, what is the time of onset of action potential? This difference between the time of onset of two action potentials, that is called jitter. In myasthenia gravis, the jitter will increase because of the reduced NMJ transmission. Okay, this test is the most sensitive test among the diagnostic tests for myasthenia gravis. Next, coming to the tensilon test or edrophonium test. So in whom we should do this test? This is particularly useful for ocular myasthenia gravis.
where electrophysiologic testing cannot be performed. So this edrophonium, what is this drug? It is a short-acting acetylcholinesterase inhibitor. So what it will do? It will inhibit the enzyme, that is acetylcholinesterase, which is responsible for the hydrolysis of the acetylcholine. So this is a short-acting drug, and it will inhibit the acetylcholinesterase enzyme at the synapse, at the NMJ. So it will increase the availability of acetylcholine in the NMJ. Okay. It is administered intravenously and the patient is observed for improvement in the symptoms of ptosis or diplopia. It has a sensitivity of 71 to 95% for the myasthenia gravis diagnosis. So it will be performed for ocular myasthenia gravis particularly. Next, coming to the other test, ice pack test. So when edrophonium testing is contraindicated, so edrophonium we cannot give to that patient. Then what we will do? We will give ice pack test. This test requires an ice pack placed over the eye for 2 to 5 minutes. So ice pack should be kept over the eye for 2 to 5 minutes. Then an assessment is done for a ptosis or diplopia. This test cannot be used for evaluation of the extraocular muscles. So this we can see any improvement is present or not. Then imaging tests, CT and MRI. So chest computed tomography. So CT of the chest or MRI, magnetic resonance imaging, should be performed in patients diagnosed with myasthenia gravis to assess the thymoma. In cases presenting with pure ocular myasthenia gravis, MRI of the orbits and the brain can be taken. So it needs to be performed to evaluate for any localized mass lesions. So in ocular myasthenia gravis, we should do MRI of the orbits and brain. And we can also do MRI of the neck for thymoma. And we can do CT of the chest also. Other laboratory tests include this myasthenia gravis commonly coexists with other autoimmune disorders. So we can test ANA antibodies, that is anti-nuclear antibodies, and a rheumatoid factor, okay, and a baseline thyroid function tests are also recommended. So all these are the tests for a myasthenia gravis. Now coming to the treatment or management. So what is the mainstay of the treatment in myasthenia gravis? So it involves cholinesterase enzyme inhibitors. So we should give cholinesterase enzyme inhibitors and immunosuppressive agents. So symptoms that are resistant to primary treatment modalities are those who require rapid resolution of the symptoms, like in myasthenia crisis. What we will do? Plasmapheresis or intravenous immunoglobulins can be used. So we will use primary treatment as a cholinesterase enzyme inhibitors and immunosuppressive agents. In myasthenia crisis or those who failed for the above treatment, we can give plasmapheresis or IV immunoglobulins. The management strategies in the myasthenia gravis are including four principles. So what are they? First, we should give symptomatic treatment. We should give acetylcholinesterase inhibitors. Okay. They will increase the levels of the acetylcholine which is available at the NMJ by preventing its enzymatic degradation. So pyridostigmine bromide is the preferred acetylcholinesterase inhibitor over the neostigmine because of its longer duration of action. But in those with the bromide intolerance, okay, because in some patients bromide will lead to GIT effects. So in those we cannot give pyridostigmine bromide. So in those patients we can give ambinonium chloride as the drug. And patients with the myasthenia gravis respond poorly to these drugs and hence they will require higher dosages. These are used when the patient is unresponsive to treatment or has any contraindication to the above treatment or intolerability for the first line agents. Then we can give second line agents. Recently, various monoclonal antibodies are identified, like rituximab and eculizumab have been used for treatment of the myasthenia gravis who are drug resistant conditions. Next, coming to the IV immunoglobulins or plasmapheresis. This is recommended during the peri-operative period especially, okay, to stabilize a patient before procedure. It is also the treatment of choice for the myasthenia crisis due to its rapid onset of action and used in cases that are resistant to immunosuppressive drugs. So, this plasmapheresis or IV immunoglobulin treatment can be given in myasthenia crisis and can be given in the peri-operative period and can be given in the patients who are resistant for the immunosuppressive drugs. And next one is the thymectomy. This is indicated for the following conditions. Those are any subtypes of myasthenia gravis with evidence of thymoma, we should do thymectomy, or non-thymomatous nicotinic acetylcholine receptor myasthenia gravis, seronegative non-thymomatous myasthenia gravis. Okay, however, it is not recommended for the non-thymomatous musk myasthenia gravis. Okay, and non-thymomatous ocular myasthenia gravis. Okay, so in musk and only ocular thing we cannot do, or we can do with the thymoma or non-thymomatous nicotinic acetylcholine receptor myasthenia gravis and seronegative non-thymomatous myasthenia gravis. We can go for thymectomy. What is the prognosis of this disease? So various clinical and laboratory or imaging findings in myasthenia gravis will show prognostic significance. So there is a risk of secondary generalization. This is associated with a late age of the onset and high titers of nicotinic acetylcholine receptor antibody and the presence of thymoma. So late age of onset, NACHR receptor antibody and presence of thymoma will lead to the risk of secondary generalization. However, early treatment with immunosuppressive drugs such as corticosteroids and azathioprine will decrease the risk. This is what is the second one? Risk of relapse of the myasthenia gravis. So when the patient has a early onset, that is less than 40 years of age onset, and early thymectomy is done, and administration of prednisolone are found to associated with the relapse of the are associated with the reduced risk of relapse. So early age of onset, early thymectomy we have done, and we have administered a prednisolone. All these things will reduce the relapse rate of the myasthenia gravis. But however, patients with anti-KV 1.4 antibodies. So these are the antibodies against the potassium channels. In some patients, they are also present. And concomitant autoimmune disease, if any other autoimmune disease is present, then these will show high rate of relapse. So what is the prognosis? There is a risk of secondary generalization. So in one part it is present, myasthenia gravis. Now it is attacked the whole body. That is a generalization, and there is a risk of relapse of the myasthenia gravis. We have to know some points about LEMS, that is Lambert-Eaton myasthenic syndrome. In this also weakness is present because of the weakness of the skeletal muscles. So what is the difference? So this is the Lems is also a neuromuscular junction disorder. So it is also an NMJ disorder, but this may be present as a paraneoplastic syndrome or a primary autoimmune disorder. Okay, so this is a paraneoplastic syndrome. Means what? A cancer is present and this is occurring. So after a small cell lung cancer, okay, this the small cell lung cancer will lead to this symptom. So the primary clinical symptom is muscle weakness, but the person is having small cell lung cancer. So in this, what is happening? The antibodies will be developed against the voltage gated calcium channels which are present on the presynaptic nerve terminals. Okay, so this is also a disease affecting the NMJ, but the presynaptic nerve terminals
voltage gated calcium channels are affected. So the antibodies are formed against the calcium channel. So what is happening? Calcium cannot be entering into the presynaptic nerve terminal and it cannot bind to snare protein. So acetylcholine release will be decreased from the presynaptic nerve terminal. Okay. So what is happening? The muscle cannot undergo into contraction. So this limbs can be paraneoplastic, that is after a cancer, that is mostly after the small cell lung cancer, or it can be non paraneoplastic also. Okay. So without that also it is occurring. So in this also, what is the condition? The person will experience weakness of the skeletal muscles. Okay. So in this, what you can see, IgG antibodies are also seen in these patients which are having LEMS. So it is a B cell mediated autoimmune disorder. So this is a B cell mediated autoimmune disorder. IgG antibodies are formed against the voltage gated calcium channels. Okay, but this is a rare condition than the myasthenia gravis. So the muscle weakness predominantly involves the proximal lower extremities. So what we have seen in myasthenia gravis, it is involving the upper arms and the proximal muscles. Here it is involving the proximal muscles but the lower extremities. So there is a difference. Okay, and here what is happening exactly opposite the myasthenia gravis. That is, after an exercise or after an activity, what is happening? There is increase in the muscle activity. So this is exactly opposite to the myasthenia gravis. So after an exercise in myasthenia gravis, what is happening? The patient will experience more weakness. But in LEMS, what is happening? After an exercise or after an activity, the patient will feel more energetic. Okay. Why? Because after an exercise, the calcium will be released more. So more ACH can be released. Here, okay. So this can be seen by enhanced deep tendon reflexes and muscle strength after repeated muscle contractions. Okay, and the oculobulbar weakness is a more prominent feature of the limbs. Okay, and in 70% of the patients, cranial nerve involvement will be observed. So mostly these LEMS patients will come as a ptosis patients or diplopia patients because of the ocular symptoms, and they can come as dysphagia patients or dysarthric patients also. Okay, and here autonomic dysfunction is also present. In myasthenia gravis, autonomic dysfunction is not present. So it is also a difference between these two. Okay. So we can also do evaluation like our myasthenia gravis only. We can do serology testing. Okay. So we can see the antibodies which are directed about voltage gated calcium channel. Mostly the type is P by Q type of voltage gated calcium channel. We can see the antibodies in serology. Okay. And we can do electrodiagnostic testing also, like myasthenia gravis. We can do nerve conduction studies, repetitive nerve stimulation test, and single fiber EMG we can do. And we can screen for malignancy. So mostly it is associated with some malignant condition. So we have to do CT scan, MRI scan, or a PET, that is positron emission tomography scan, mostly of the chest. Okay. So the treatment should be like this only. Acetylcholinesterase inhibitors we can give, and we can give 3,4 DAP, that is diaminopyridine. So what this the diaminopyridine will do? This will block
the presynaptic potassium channels, and it will prolong the duration of the action potential. So what is happening? This diaminopyridine will block the uh, presynaptic potassium channel. So potassium cannot go out of the cell. So it will lead to prolongation of the action potential. So it leads to release of entering of the calcium into the presynaptic nerve terminal. And we can give intravenous immunoglobulins. Okay. And we can give steroids and immunosuppressive drugs same as myasthenia gravis, or we can plan plasma exchange or plasma pheresis. Okay. So the differential diagnosis should be mg. Okay, so these Lems and mg are almost say they are looking same. So the differential diagnosis are mg for Lems and Lems for mg. Okay, then the next video is about denervation hypersensitivity.